Uh,
Okay.
2-year-old boy's mother reports history of dribbling and poor urinary stream since birth. Prenatal ultrasound scan performed at 36 weeks of gestational age revealed moderate hydronephrosis and oligohydramnios. Child is currently stable, afebrile, and feeding well. Right? On examination, a palpable bladder is noted. What is the most appropriate initial next step? Right. So, what do you think is this child having? Right now, you need to know this if you're going to write for the pediatric paper. Rishni, what is this child having?
Is it posterior urethral valve?
Yeah. Ale, can you tell me why do you think that is the most likely diagnosis? Hmm. Okay. So, if a child is having posterior urethral valve, Deshabandu, what are the risk factors the child can have? What are the risks the child will have after birth?
Urinary tract infections.
Okay. Severe urinary tract infection. Anything else? Can it lead to hydronephrosis and CKD?
Yeah.
How?
Yeah. Because the backflow to the towards the kidney.
Good.
Then,
so, what is the gold standard investigation to evaluate the lower urinary tract? Gold standard investigation to evaluate the lower urinary tract. What is the gold standard investigation? Darla?
For UTI, right?
Huh?
Lower urinary tract infection.
No, not infection, lower urinary tract. To detect any anatomical defects, what is the gold standard infection investigation?
Ultrasound scan.
Ultrasound scan. Anything else?
Is it MCUG?
It's MCUG. Excellent. So, what are the investigations to investigate the lower urinary tract or the urinary tract per se in children? So, we shall call this imaging investigations of the urinary tract. Right? Right? So, what are the investigations, Jarna? Shall we start from here? So, shall we divide this into upper urinary tract and lower urinary tract? What are the upper urinary tract investigations?
We start with ultrasound scan.
Okay.
Imaging. Ultrasound scan. KUB.
Okay.
And then.
You can also do what? Come on. You have to know now.
Huh?
You have to know now. What is the other tests to check the upper urinary tract? Listening?
DMSA, we can DTPA.
What does DMSA check for?
DMSA checks for renal scarring and DTPA for renal function.
Right. If there is a obstruction at the pelyureteric junction, what is the best investigation you can do to diagnose that?
Pelyureteric junction, DTPA.
Why?
Because we are looking for the renal functions. So, in that case, DTPA would be more appropriate in this.
No, it's because the secretion of the DTPA radionucleotide will be delayed in pelyureteric junction obstruction, not because of reduced function, okay? But that is the best investigation to diagnose that. If you are thinking of a problem in the vesiculoteric junction, Ale, what is the best investigation you can do to diagnose that? Vesiculoteric junction. MCU? Sure.
By that same concept, won't DTPA make sense again?
Not really. Not really. because you can't identify the obstruction clearly with the DTP if you use it for the vesicular junction obstruction. What is the best investigation for vesicular junction obstruction? Have you guys heard of CT-IVU? Or in other words,
Yeah.
yeah. Or in other words, you can do something like what do you call this? I remember the name of that. Contrast nephrostomy, contrast nephrostogram. So you give contrast to the kidney to the bloodstream, and it is excreted by the kidney, and you take X-rays and see. I can't remember the name of that investigation. What are the lower urinary tract investigations that you can do? This is for all urology, right? Not only this pediatric one. What else? Hello?
MCUG is one.
Yeah, MCUG for what mainly?
Posterior urethral valve.
Okay. And bladder outflow tract obstructions also commonly, but mostly for posterior urethral valve. Anything else? Excellent. Cystoscopy and urethrostomy. Usually urethrostomy is not done. Usually what they do is cystoscopy. With that you see the urethra also. Okay. So these are the investigations that you can do, right? So what is the next best step in management? What is the best way to decompress?
එයාට මේ urethral catheterization එක කළා බැරි නම් ඒක කරන්න පුළුවන් නේද?
Yeah. Best way is urethral catheterization, right? So when you have a pelviureteric junction obstruction, right? So this is a posterior urethral valve. The management is this. Now, after immediate detection, usually these patients are detected in the antenatal period, in the anomaly scan. That is why you take an antenatal history in the pediatric long case history, right? Anomaly scan, usually they will find the posterior urethral valve nowadays, but even if they don't find, they will find abnormal antenatal findings like oligohydramnios and visible bladder and hydronephrosis. So after being born, the first thing you do is an immediate ultrasound scan of the kidney ureter bladder to identify the posterior urethral valve. That is the first thing you do, right? And then the next thing you need to do is you need to confirm this by organizing a MCUG. But while this is being organized, you also need to do immediate decompression of the bladder. So that immediate decompression of the bladder is done with two methods. You can first try urethral catheterization. Ale, why can you do urethral catheterization first without trying a suprapubic catheterization? Yeah, and also the posterior urethral valve is such that it is a one-way valve, right? So it is like this against the bladder. So bladder urine it finds difficult to go through, but if you insert a catheter through this, it's like a saloon door. So you can like not a saloon door, it's a one-way door. So you can just insert it through the posterior urethral valve without causing any obstruction there. So urethral catheterization is number one, and then you can of course try suprapubic catheterization. And then after immediate decompression, you need to do the surgery. What is the surgery that you do?
Cystoscopic ablation.
That is the definitive surgery. Until the cystoscopic ablation of the posterior urethral valve, what do you do? Come on, guys. You create a vesicostomy. Have you guys seen these children with posterior urethral valve? They have a small, what do you call, if you take the belly button like this and the small two leaves like this, they have a small opening here just above this pubic bone. That is just the bladder that has been taken out by the surgeon. Understood? So that all the urine is now coming here, because children can't be catheterized for a very long duration or so. Usually catheters, how long can you keep a catheter? Silicone catheters you can give up to 6 months. Usually other catheters 2 weeks to 3 weeks. Right? 3 months.
Oh,
Right.
3 months නේද බා මට මතක තියෙන්නේ.
Right. Okay. So, the latex, what do you call that catheter? Foley catheters, usually you can keep up to 2 to 3 weeks. Right. So, this is urgent. What is the next most appropriate initial next step? Of course, urgent ultrasound scan abdomen, it's not that important because anyway, this is like posterior urethral valve and you can't confirm the diagnosis by the ultrasound scan. So, it won't really do any additional benefit. So immediate urethral catheterization is the next step. Did you guys understand posterior urethral valve?
Yes.
This is more common in boys or girls?
Boys.
More common in boys. Can girls get posterior urethral valve? Ale? They cannot get posterior urethral valve. ඒක හොඳට බලන්න. හරි කොල්ලන්ට විතරයි එන්න පුළුවන්. ඒකට හේතුව තමයි අර ප්‍රොස්ටේට් එක තියෙන හරිය අවුලක් ගියොත් තමයි posterior urethral valve එන්නේ. හරි? Those are basic things, huh? You need to remember. තේරුණාද?
Arunaja, is there something called a uroflowmetry?
Yeah, that is not diagnostic of posterior urethral valve. But you can of course do uroflowmetry. That is actually not to image the urinary tract. That is to identify any micturition problems.
Oh, okay.
Micturition is a combination of both the upper tracts and the lower tracts. Mainly the bladder and the lower urinary tract. So this is structure and the physiology is the micturition. So for this you can do, again you can do ultrasound scan, KUB, and you can see the residual volume. And then you can also do uroflowmetry.
Like for instance, like in a neurogenic bladder, is that the?
Yeah.
Okay.
To identify neurogenic bladder per se, you need to do this. But for posterior urethral valve, you get a neurogenic bladder?
No.
No, you don't get a neurogenic bladder, right? You get a high pressure system. Understood?
Yeah.
Okay. So I'll go to the next one. Then make it in a වැදගත්කම තමයි you need to identify. This comes in the UTI long case. You need to identify the investigations and their timing depending on the UTI, nature of the child in the long case, right? Because you have to know how to further manage this child's UTI problem in the long case, and you also need to know how to prepare a child for a MCQ. Read around that, right? There are these additional points which you will ask in your exam, right? There are everyone?
Yeah.
Okay. So we'll go to the next one. 4-year-old boy presents to the emergency department with a 12-hour history of severe colic abdominal pain, non-bilious vomiting with abdominal distension. He has not passed stool for 2 days. On examination, a left-sided tender irreducible inguinal hernia is noted. What is the next best management option? So this is a irreducible means it's either incarcerated or strangulated inguinal hernia, right? This can be either an incarcerated or a strangulated inguinal hernia. If you see a child with the inguinal hernia, do you do the operation then and there? Is it an emergency operation? That's actually a wrong question to ask. But is it an emergency cause for surgery? To say a child with the inguinal hernia? Yes or no? දේශබන්දු? මෙයා කියලා දීලා තියෙනවා මේ ඉස්සෙල්ලා MCQ වල.
ඉන්ගොයිනල් හර්නියා එකේ විමර්ශන මේ අර ඒක පොඩි මේකට නේ ෂුවර්.
It is emergency.
Test. Yeah.
Yeah, it is emergency. You need to do it. Why do you need to do it early? Listening.
Yeah, I'm not sure why.
It's because the children usually they will present with incarceration or strangulation very commonly because their inguinal canal is very narrow. Understood?
Yeah.
They have small pelvis, no? So he presents it without any stools for 2 days. So what is this clinical picture now? What is the clinical picture? Yeah, this is bowel obstruction. So now what do you need to do? Yeah, first you need to decompress the bowel. So that is with the nasogastric tube, and you also need to manually reduce the hernia. You can try to manually reduce, but you don't do manual reduction in all the cases. Out of these two, where would you do the manual reduction? Incarceration, the strangulation again. Strangulation again. No, incarceration එක තමයි එහෙම කියන්නේ. Right. Why don't you do it in the strangulation? Manual reduction? It will rupture inside, right? If it ruptures inside, there will be peritonitis. So you never reduce it if this is confirmed to be strangulation. But he only has a 12-hour history of the symptoms. So he has had hernia, but he has had the pain and the symptoms for 12 hours. So this can be incarcerated also, right? So how do you identify as incarceration and strangulation of a hernia clinically? හැමදාම කන්ටිනියස් අහන්න ප්‍රශ්න. අපේ හමු සර්ජරි තියෙන කට්ටියගෙන්නේ දේශබන්දු කොහොමද incarceration and strangulation වෙන් කරලා අඳුරගන්නේ clinically?
I'm not sure.
With tenderness?
Yeah, because of colicky pain. Colicky pain is usually incarceration. But constant dull pain is usually strangulation. Why is that? Because if the bowel is moving only, you get the colicky pain. Right. We'll go to the next one. Shape අපේ මේ මලික්ස කියනවා usually ice packs තියන්න එපා කියලා. මලික්ස කියනවා manual reduction උත් කරන්න එපා කියලා. එයා personally කියන්නේ immediate emergency laparotomy කරන්න කියලා. But first, in this patient, the priority should be, if it comes for SCQ, you need to resuscitate the patient. That is the first thing you need to do. And then you need to decompress the bowel, right? And then you need to decompress the bowel. And then you also need to do the basic investigations first, right? Basic investigations need to be done. And then only you need to send the patient for, you can do a manual reduction, right? Manual reduction. And if it is not manually reducing, or if you are highly suspected of strangulation, you need to go for emergency laparotomy. තේරුණාද මේකම අහන්න පුළුවන් surgery වල ඔයාලගේ මේ SCQ එකකදී. Understood? These are common things නේ. ඊළඟට යනවා. 6 months old term baby is reviewed in pediatric cardiology clinic for the evaluation of a heart murmur. Echocardiogram reveals moderate size patent ductus arteriosus with associated dilatation of left atrium and left ventricle. The baby is entirely asymptomatic and growth and development are normal. What is the best intervention at this stage? Now what is he having? He's having a patent ductus arteriosus. It's a moderate size, relatively large one also. There is dilatation of the left atrium and left ventricle. Why do dilatation of the left atrium and left ventricle take place in patent ductus arteriosus?
Pulmonary.
Huh? Yeah, this is because of volume overload. Because patent ductus arteriosus is pumping blood from the aorta to the pulmonary vessels, and that blood is coming to the left ventricle and left atrium. So there is volume overload. So will this patient become heart failure later on? Yes,
Yeah.
patient is impending heart failure. No symptoms. What is the heart failure stage of this patient? Heart failure stages හතරක් තියෙනවා A B C D කියලා. Medicine වල කතා කරා. What is the stage of this patient? Stage B වගේ නේ. Symptoms නැහැ උනාට ඔක්කොම heart එකේ structural features තියෙනවා. Right? So what do you need to do? Best intervention at this stage. How is patent ductus arteriosus usually corrected? Guys,
Paracetamol?
paracetamol? Yeah, true. That for a very small patent ductus arteriosus, you can do paracetamol. Is it oral or IV?
I'm not sure about that.
IV paracetamol, right? And then if it is not closing with IV paracetamol, what do you do? You try device closure. Device closure in the sense you send a coil through your arterial system and you close the PDA. If this also doesn't close, what do you do? PDA manual ligation via surgery. Right? Understood? This was the first cardiac surgery done for children. Right? For children, PDA surgery. Earlier they didn't have device closure or IV paracetamol. Understood? Okay, so now what do you think is the correct answer here? Surgical intervention at 5 years of age if the child remains asymptomatic. True or false? Repeat echocardiogram and clinical assessment in 6 months. True or false? Start indomethacin infusion immediately to attempt PDA closure. You don't give indomethacin now. That is out of practice. So all of these three things are false. We can't wait now. Understood? So what do you need to do now? You can do urgent percutaneous device closure within the next few months, and you can also do the surgical ligation of the PDA now itself. What do you think is the best one now? What do you think is the best one?
There is impending heart failure, so the best would be to do an urgent surgical ligation.
Okay. Ale, what do you think? This is the correct one. Urgent percutaneous device closure within the next few months. This is not an urgent surgery. They're not. The child is. This is not an urgent surgery. Why do you need to take some time before cardiac surgery? Why can't you just do it on the table itself? Nah, it's because spontaneously වැහෙනවනම් මචං දැන් වෙති වැහිලා තියෙනුනේ PD එක. එහෙම වැහිලා නැහැනේ. The reason is you need to take time to prepare the patient, optimize the patient. Right? So you need to take time to optimize the patient. So what is the ideal time to correct a PDA? අද කට්ටිය කතා නැහැනේ.
අද පීච් සර්ජරි කැඩෙන්න.
මේ මෙච්චර ඩීටේල් එකේ කියන එක හොඳයිද නැත්නම් ඔයාලා මොකද හිතන්නේ?
හොඳයි බං අවුලක් නැහැ. ඔව් අපි මේක පොඩ්ඩක් බලලා අඩුයි බං පීච් සර්ජරි part.
What is the ideal time to close a PDA? We'll see.
Less than 1.
Did you guys find an answer? Right. So, asymptomatic PDA are treated by ligation or division of the ductus, preferably between 3 to 10 years of age. Symptomatic patients should be surgically corrected irrespective of age and presence of pulmonary hypertension. Surgical closure is by division or suture of ductus. The latter technique is considered better. Right? Imata දැන් කරන්නේ මේවා දැන් මේ පරණ පොතක් හරි. Medical management consists of chronic cardiac failure management and infective endocarditis treatment. මේක මොකක්ද දන්නේ කියන්නේ නේ concise එකේ.
concise එකේ මචං තියෙන්නේ මේ treatment options for PDA include medical interventional or surgical closure. Medical closure okay ටික කියනවා මේ paracetamol or NSAIDs in both preterm and term babies during first 2 to 3 weeks of life කියලා. ඊට පස්සේ interventional closure using device or coils is undertaken when the baby achieved a weight closer to 5 kg කියලා. Surgical closure is indicated especially in premature low birth weight babies who cannot be weaned off the ventilator.
Right. The surgical closure is too invasive. We can take time and do it. Right? So percutaneous device closure is the best one here. Always go with the non-invasive option. Understood? Then now the baby is investigated for excessive weight. Birth weight is 2.9 kilogram and the current weight is 2.5 kilograms. She is afebrile, alert and icteric. So 7-day-old baby. So this is late icterus, right? Birth weight is 2.9, current weight is 2.5. Febrile, alert and icteric. She is passing urine 5 to 6 times per day. And she is vigorously sucking during feeds. Investigations show serum sodium levels 152, slightly increased. Potassium increased. Total bilirubin increased. Direct bilirubin normal. Right? Is this direct or indirect bilirubin? Hello? This is also normal.
If it's direct bilirubin is normal, then it's supposed to be indirect bilirubin. Right?
Yeah, this has to be indirect, right? Platelet count is also normal. White blood cells is also normal. Neutrophils is slightly increased, but this is normal. Right? This is also normal for that age. Okay, so we'll see what is the single most important appropriate next step of management. What is the age of the child now? 7 days. He's icteric. She's passing urine 5 to 6 times a day. So she's well hydrated. No, that means the baby is well hydrated. Understood? Baby is well hydrated. So can this be breast milk jaundice?
No.
Unlikely to be breast milk jaundice. Can this be physiological jaundice?
Also can't.
Yes, it can be physiological jaundice. Right? Can be physiological jaundice. Right? And this is indirect hyperbilirubinemia also. No? Remember that day I told you the different types of bilirubinemia and the examples for that. You need to remember that, right? In pediatrics, especially in neonatal jaundice. So what is the most appropriate step of management? IV normal saline fluid balls. Is there a need to give IV normal saline? No. Why? Initiate intravenous normal saline with 5% dextrose fluid. Never. Conduct full septic screening and commence broad spectrum intravenous antibiotics. Wait. Commence phototherapy. Initiate top-up formula feeding. Now, this baby's weight loss, what is the weight loss of this baby?
Yeah, more 6%. Yeah, more than
13%. 13%.
Right? So, about more than 10%, usually within 10 days, within 5 to 7 days, you can lose up to 10%. And then within 10 days, it has to reach birth weight. 5 to 10. 5 to 7, within 10 days, it has to reach birth weight. Make sure, mother. Within 10 days, has to reach birth weight. Right. So, this baby is having loss of weight that is significant. Now, she's urinating well. 5 to 6 times is normal. Alright. 10 to 14 days. Right. So now this baby is 7 days, 10% loss. That is abnormal, right? So now this baby is feeding well also. Vigorously sucking during feeds. Feeding avulak වෙන්න බෑ නේද? මොකද urination avulak නැහැ. ඔව් ඒක ඉතින්
අවුලක් නැහැ නේද?
ඒක ලොකු අවුලක් නැහැ නේ.
6ක් වගේ යනවනේ.
ඔව් එක වතාවෙනේ මිස් කරලා තියෙන්නේ සමහරලාට අම්මා දන්නේ නැතුව පැම්ප් එකේ ගියත් දන්නේ නැහැනේ. එතකොට investigation show මේ ටික තමයි තියෙන්නේ indirect hyperbilirubinemia තමයි වැඩි. මේ වගේ ප්‍රශ්නේ තියෙන මෙන්න මෙතන potassium level එකයි sodium level එකයි වැඩි. WBC
WBC වැඩි නේ බං. ඉන්ෆෙක්ෂන් එකක් තියෙනවනේ.
count එක වෙනස්. මෙතන neutrophils 78% වෙන එක abnormal නේ. Yes. මොකද hematocrit එක normal නේ බං. මේ ගන්න normal. අපිට තියෙන 45 නේ. පොඩි කට්ටියක වැඩි මං හිතන්නේ hematocrit එක. මෙයාගේ this is abnormal because in children lymphocytes are the, especially neonates, lymphocytes are the predominant cell group, right? It can never be neutrophils. If this was an adult blood film, it will be normal, but in this child who is a neonate, this blood film is abnormal, right? So to me it looks like he is having some renal failure as well because urea levels are increased, right? So septic shock was given. Right? Can we measure the blood pressure in this child? Trisni?
no, right? Still,
No.
so we can't do.
So the best way is to do a full septic screen and commence broad spectrum antibiotics. Why? Is sepsis a cause of hyperbilirubinemia in children? Ale? What does it cause? What sort of hyperbilirubinemia does it cause? Good, indirect hyperbilirubinemia. So we go to the next one. A preterm. So this apnea thing again. A preterm newborn baby has 3 distinct episodes of apnea at birth, which responded promptly to simple tactile stimulation. In between these episodes, the oxygen saturation remains stable at 95% on room air. Mother was started on benzyl penicillin 3 hours ago. What is the single most appropriate next step of management? So what is the next step of management? We need to give broad spectrum antibiotics to the child as well. Because this apnea can be due to, number one, it can be due to apnea of prematurity. Okay? It can be apnea of prematurity. And it can also be due to neonatal sepsis. It can be due to apnea of prematurity and neonatal sepsis. usually if the baby is maintaining saturation, right? The baby is maintaining saturation between the apneal episodes, you don't need to give. You do not give, right? You do not give caffeine. You don't give what do you call this, CPAP, and you don't need to give oxygen support. Oxygen support එක නම් දෙනවා හැබැයි හරි. ඒක දෙන්නේ නැතු වෙන්නේ නැහැ. CPAP දෙන්නේ නැහැ. Caffeine දෙන්නේ නැහැ. ET tube ventilation never. හරි. Because this baby ඒවා දෙන්නේ නැත්තේ SpO2 maintain වෙනවා නම්. SpO2 maintain වෙන්නේ නැත්තම් හරි recurrent apneic attacks තියෙනවා නම් recurrent apneic attacks their SpO2 reduces less than 98%, you give caffeine first, see the baby starts picking up his respiration. If not, you start immediately on CPAP. If that also doesn't work, ET tube ventilation. But
recurrent තියනවා නේද?
Recurrent තියෙනවා. හැබැයි recurrent apneic attacks with reduction of saturation remain stable at 95%, not room air. Right? එතකොට මෙයාට support දෙන්න පුළුවන් අපිට nasal prong oxygen එක. හැබැයි single most important next step එකේදී අම්මට benzyl penicillin දීලා තියෙන හින්දා this can be neonatal infection or and sepsis. So better to start a broad spectrum IV antibiotic. තේරුණාද? Understood?
Yeah.
What is the antibiotic?
මාෂන් මේ අරකෙදී අර saturation normal වෙලා මේ recurrent attacks උ නැති වුණොත් අපි caffeine දෙන්නෙත් නැහැ, CPAP දෙන්නෙත් නැහැ, මේ මේවා කරන්නෙත් නැහැ නේ. හරි බං හරි.
What is the most important broad spectrum antibiotic you give to these children? Hello. You give IV what? අම්මට දුන්න එක දෙන්නේ IV benzyl penicillin. And what else can you give as the antibiotic to cover the gram negatives? Gentamicin. These are the only two antibiotics on Unix. මෙයා මතක තියාගන්න ඕනේ basics. Okay, so we go to the next one. Regarding a 12-year-old child ingested 15 paracetamol tablets 1 hour ago, asymptomatic, what is the next step of management? Now, according to the poisoning principles discussed in the medicine MCQ, you have to be able to answer this. 1 hour ago, what do you do? Quickly.
Charcoal දෙන එකනේ.
Activated charcoal and gastric charcoal. That's it. ගහලා ගියා. I'm not going to describe it later. You have to know and read about paracetamol poisoning. Okay. Read about paracetamol poisoning management. So I go to the next one. A 13-year-old girl with unilateral throbbing headache for 3 hours, photophobia, few days per week, currently on inhaler for asthma. What would be the best management step? Best management step. What is the most likely diagnosis of this headache syndrome?
Migraine, ne? Unilateral.
Okay, migraine. Per week, currently on inhalers for asthma. Right?
Beta blockers.
What is the importance of that?
We can't give beta blockers.
Yeah, we can't give beta blockers. So propranolol is out. CT brain, do you need to do a CT brain? No.
I mean,
Do you need to do a symptom diary? Not needed, no? This management option, what do you do? It's chlorhexidine. What are the abortive treatment and prophylactic treatment for migraine? How you have to mention these things? Abortive treatment, what are the abortive treatments? Go. මේ මේවා දැනගන්න ඕනේ. Paracetamol, NSAIDs, what else? Prophylactic treatment මොනවාද? මේ මේවා දැනගන්න ඕනේ. මම ගිය පාර කිව්වනේ මේක මේ මෙඩිසින් MCQ එක කරත් මේ ටික බලා ගන්න කියලා. බලාගත්තේ නැද්ද?
බලාගත්තොත් මතකයි.
මතකයේ තියෙන කියමු මොනවද prophylactic treatment දෙන්නේ?
ප්‍රොෆිලැක්ටික් SSR ඒව පුළුවන් නේ.
Okay, DCA and SSRI. Anything else? Beta blocker.
ඔපිරමේට් තිබ්බද?
ඊට පස්සේ තව මොනවද දෙන්න පුළුවන්?
ඔපිරමේට් තිබ්බනේ.
CGRP receptor agonists කොහෙද තිබ්බ නේද? අර ජිපෑන්ස් කියලා තිබ්බේ. නෑ. ඒවා serotonin receptor antagonists. Sumatriptan, zolmitriptan ඒවා. මේ ටික බලාගෙන මටත් හරියටම දැන් මතක නෑ. දැම්ම බලාගමු නැත්නම් ඔකයි ඔයාලා බලන්නේ. මේවා අහනවා මොකද මෙයා ලේසි MCQ අපරාධයි. These are the ones. Depends දෙකටම දෙනවා කියලා දෙනවානේ. Right? Beta blockers දැන් use කරන්නේ නැහැ කියලා තමයි specify කරන්නේ. Right? These are more effective. These are the most efficacious preventive medication for migraine. Right? Flunarizines. Flunarizine කියන්නේ triptan එක. And these are the most effective abortive treatment. Okay? We go to the next one. 10-year-old boy with fever, vomiting, abnormal behavior for 1 day. GCS was 10. Low blood pressure, irregular respiration was detected. CT shows diffuse cerebral edema. Next step of management. Someone? Fever, vomiting, abnormal. GCS was 10. Low BP. Yeah? What is the first step in resuscitation? Airway protection.
Airway protection.
This child does not have any features of respiratory, like he has impending features of respiratory failure. They are not. Then GCS 10 කියන්නේ මචං මෙයාට ඕනම වෙලාවක යන්න පුළුවන් GCS 8 වලට. Impending features තියෙනවා. ඒකද better to secure the airway and then manage. They are not. So why do you think this child has this picture? What is the diagnosis here? Jarna? Fever, vomiting, abnormal behavior, low BP, encephalopathy වෙන්නත් පුළුවන්. Any other causes? Encephalitis. Encephalopathy කියන්නේ වෙනස් එකක්. Encephalopathy කියන්නේ brain එකේ function එක deteriorate වෙනවා metabolic reasons හින්දා. Hepatic encephalopathy, uremic encephalopathy මේ වගේ දේවල් හින්දා. Encephalitis කියන්නේ brain matter එක ඉදිමෙනවා, right? ඒක තමයි මේ diffuse cerebral edema එකකින් කියන්නේ. තේරුණාද? It's better to intubate and ventilate, even though GCS is more than 8. Because she is having irregular respiration. Right? So we'll go to the next one. Oh, income macam units වල treat කරන්නේ NaCl and mannitol දීලා. ඒනට ඒ වල evidence අඩුයි. එතකොට මොකක්ද හරි මේක කියලා කියන්න දන්නේ කවුරුවත්. ඒක ඒ යුනිට් ප්‍රොටෝකෝල් එක අනුව තමයි ට්‍රීට් කරන්න එක හොඳ. IV acyclovir ට්‍රීට් කරනවා අනිවාර්යයෙන්ම. ඊට පස්සේ තව IV antibiotics උත් දෙනවා. ceftriaxone කියන එකක් දෙනවා. IV ceftriaxone, IV acyclovir දෙනවා. ඊට පස්සේ patient මේ intubate කරලා ventilate කරනවා. patient ගේ fluid balance එක බලනවා. blood pressure stable තියා ගන්නවා. fluid balance එකයි vasopressors හිමත් දෙන්න පුළුවන්. ඊට පස්සේ patient ගේ ICP reduction එකට හොඳම වැඩේ unit protocol එකට stick වෙලා neurosurgical referral එකක් දාන්න. තේරුණාද? ඊළඟ එක 29 a 10-year-old boy presents with sudden onset shortness of breath while eating peanuts. Respiratory rate 22, mild dyspnea and coughing. Right hemithorax air entry reduced. Urgent chest X-ray shows complete right-sided lung collapse. What is the best action to be taken? What is the best action to be taken?
Bronchoscopy.
Perform bronchoscopy. ඇයි මේක කරන්නේ නැත්තේ? Back blows and chest thrusts.
පොඩි ලොකු වැඩි නේ.
Excellent. Because this is done for choking. Choking is done. Choking is where there is obstruction of the obstruction above the bifurcation, right? Obstruction above the bifurcation, right? ඒත් කොට අයින් කරන්න ඕනේ. දැන් එක පැත්තක් කලෙක්ට් වෙලා දෙද්දී ඕක කරොත් ඒකේ අනිත් පැත්තට යයි. ඒකින්ද you need to do manual removal of the foreign body in here. තේරෙනවද? Jharna, understood? Jharna is very quiet. I think she's sleeping. So how do you what is the complication of lung collapse? What are the complications of lung collapse? If there is atelectasis, if there is atelectasis, they can get infections, pneumonia, and later it can lead to bronchiectasis, and it can also lead to pulmonary fibrosis. These are the complications. So you need to prevent these complications as much as possible, as soon as possible. So the best way is to re-expand the lung. Re-expansion is done automatically, but you need to help it by removing the foreign body. Understood?
Yeah.
We go to the 30th one. 14-year-old boy with blood and mucus diarrhea for 2 days, oliguria for 3 days. No hypovolemia. What is the next step of management? What does this look like? Okay.
This.
AKI comma, but due to what? HUS. Excellent. Yeah. So what happens in hemolytic uremic syndrome?
Hemolysis.
Yeah, there is a E. coli toxin.
E. coli toxin.
E. coli strain. 0.
Shiga toxin.
Oh, AK Shiga toxin देगा. Shiga toxin නෙමෙයි. වෙනම toxin එක.
ෂුවර් නේ මම බලන්න.
ඒ toxin එක ගිහිල්ලා it causes it when it's in there's the circulation, it stimulates DIC, and this leads to MAHA also. That's what happens, and then if this takes place in the kidney, it causes renal failure. So what do you do now? What do you do? Before that, what can you do? Monotestic. Yeah, you need to do the renal function test. Why? You need to identify there is a AKI first, and then you can do everything. Renal function test වලට serum creatinine, EGFR, serum electrolytes, sodium, potassium, ටික. the ටික ඔක්කොම එනවා. So better to do a renal function test. තේරෙනවද? right? අදට ඇත්තේ නේද? පිට 10ක් කරලා ඊළඟ දවස් 10ක් කරනවා. Okay, happy new year. මේ new year එක use කරන්න once and for all ඉවර කරලා දාන්න මේක කොහොමද? All the best, do your work well. I'll meet you tomorrow to see cases, okay?
Okay, Macha.
Okay.
Thank you, Bang.
Thank you.